A 50-year-old male comes with high fever and burning micturition. He is diagnosed with urinary tract infection. Over the next 2 days, he becomes septic. Then he suddenly develops breathlessness. Chest X-ray shows diffuse opacities in the lung. Heart is normal. So, if it's not the heart, what is filling the lung? Let's break it down at the level of the alveoli. I'm Nabeel. This is Pathocyte. This condition is called acute lung injury. This is the underlying pathological process. If this process presents clinically as severe respiratory failure, then it is called Acute Respiratory Distress Syndrome. The histological or microscopic features of this condition is called diffuse alveolar damage. So, acute lung injury is the basic pathological process, ARDS is the clinical feature, and diffuse alveolar damage is the microscopic feature. All three are basically the same disease. In this video, we look at the causes, the pathogenesis, microscopic features, and clinical features of acute lung injury. We talked about the 3-question framework for lung diseases in the previous video. Whenever you study a lung disease, ask 3 questions. 1. Where is the disease occurring? In acute lung injury, it is occurring at the level of alveoli and the capillaries. What is happening? Inflammation and destruction of the alveolar wall and capillaries. What is the effect? Since oxygen cannot get into the blood, severe hypoxemia occurs. Before we understand the mechanism, we need to look at the triggers or causes of acute lung injury. For ease of understanding, they can be grouped as direct and indirect. Among direct causes, lung infections are the most common ones. They can be viral, which includes the notorious COVID pandemic which occurred recently, mycoplasma, tuberculosis, etc. Aspiration of stomach contents is another cause. The indirect causes include sepsis, the most important cause, like in our case, and any sort of severe trauma causing systemic inflammation. More than 50% of the cases are due to these causes. Other causes include shock, burns, toxins, drug overdose, and even transfusion associated lung injury. Now let's look at the pathogenesis of acute lung injury. The first step is activation of endothelial cell. This can happen directly, as in case of sepsis, where circulating inflammatory cytokines can directly activate the endothelial cells. Or the activation of endothelial cells can be indirect when alveolar epithelial cells are injured. When these alveolar epithelial cells are injured, the macrophages within the alveoli detect this and they secrete cytokines like tumor necrosis factor alpha, which in turn activates endothelial cells. Once the endothelial cells are activated, they become sticky for neutrophils. Also, these endothelial cells become very leaky. So, circulating neutrophils can come and get attached to endothelial cells. From here, these neutrophils can go through the leaky endothelium into the interstitial space, and from the interstitial space they enter the alveolus. Once the neutrophils enter the alveolus, they produce proteases, reactive oxygen species, and cytokines. This produces a self-amplifying inflammatory loop which eventually destroys more and more of alveolar epithelial cells. These leaky endothelial cells let out protein-rich fluids into the interstitium, which later enters the alveolus. This is inflammatory exudate and not transudate. This edema fluid, along with all the injured necrotic alveolar cells, produce a very characteristic finding in this disease. These two form a membranous structure around the alveoli. This is called hyaline membrane. This acts as a barrier, so gas exchange fails. All of this together produces diffuse alveolar damage. Now, what happens to the patient? Severe hypoxemia, which leads to central cyanosis and respiratory failure. Even oxygen therapy may not help. Why? Because oxygen cannot travel from the alveolar side into the capillaries because of hyaline membrane. This causes a ventilation perfusion mismatch, and this worsens hypoxemia. Now let's look at the morphology of acute lung injury. The lungs become heavy, reddish and boggy, like wet and muddy. And microscopically, in the initial stages you see congested blood vessels, interstitial and intra-alveolar edema, lots of inflammatory cells, and the classic hyaline membrane. Some of the alveoli may be dilated, while some may be collapsed. This entire microscopic picture is called diffuse alveolar damage. These hyaline membranes are similar to those seen in neonatal respiratory distress syndrome, classically called as hyaline membrane disease. Same morphology but different mechanism. Now here in diffuse alveolar damage in the later stages, type 2 pneumocytes proliferate, and later on repair occurs through fibrosis. To summarize, we saw that acute lung injury is a condition where there is bilateral pulmonary edema and sudden hypoxemia in the absence of any heart disease. Acute respiratory distress syndrome is a clinical manifestation of acute lung injury, while diffuse alveolar damage is the microscopic picture of acute lung injury. Then we saw that sepsis is the most important cause of acute lung injury, while gastric aspiration, viral infections of the lung, or severe injury or trauma can also cause acute lung injury. Then we looked at the pathogenesis, where endothelial activation is the first step, which can be direct through sepsis or severe trauma, or indirectly activated through injury to epithelial cells. Once endothelium is activated, neutrophils can get stuck onto the endothelium, then pass through the endothelial gaps and reach the interstitium and later into the alveolus, where they produce cytokines and other things which destroy the epithelial cells further. Leaky endothelium also causes edema of the interstitium and also the alveolus. This destroyed necrotic epithelial cells and the edema fluid, which is basically an exudate, will finally form the notorious hyaline membrane. Clinically, the patient has hypoxemia, cyanosis, and usually they go into respiratory failure. And under the microscope, we see congested blood vessels, lots of inflammatory cells, classic hyaline membrane, and some dilated and collapsed alveoli. This entire thing is called diffuse alveolar damage. So what looks like a complication of sepsis is actually a diffuse injury at the alveolar level. And if you truly want to understand it, think at the cell level.